Hi, it's Chris Flanagan. Welcome to the Paediatric Emergencies podcast. I'm currently in the process of writing a course manual for the Paediatric Emergencies Intubation course. For each of the chapters, I'm trying to have a talk summarising the chapter. So this is the one for the Intubation Pharmacology chapter. You can find the written text on the Paediatric Emergencies website, so that's paediatricemergencies.com. And I've created a separate tab at the top for the Paediatric Emergencies Intubation course. So as always, get in touch if you have any comments or queries, and you can expect a few more podcasts on topics related to paediatric intubation over the coming weeks and months. So there's 3 groups of medications you need when you're going to intubate a child. There's an induction agent, a muscle relaxant, and rescue medications. So the induction agent is what causes unconsciousness in the child. Firstly, so they're not aware of what's being done and they're comfortable. And the second thing it does is it blunts the sympathetic response caused by the stimulus of laryngoscopy. And this sympathetic response can actually be harmful in certain circumstances because it causes tachycardia, hypertension, increased afterload, and increased oxygen requirement on the heart. And certain groups of children may tolerate this particularly badly. The muscle relaxant is what actually lets you do the intubation. So it causes the muscle tone to relax and abolishes the protective airway reflexes, allowing you to put a laryngoscope into the back of the throat and get a view of the airway. It also causes the vocal cords to relax in the open position and allows you to pass an endotracheal tube. So you could intubate a patient with just the muscle relaxant. It's the drug that lets you do the intubation, but the patient would be fully awake and aware. So that's why you need a combination of the induction agent and the muscle relaxant. And the process of intubation is highly likely to cause hypoxia and bradycardia when you're dealing with sick children. So you need to have some rescue medications prepared to deal with these predictable complications. So in this talk I'm going to look at the induction agents, the muscle relaxants and the rescue medications and go through them in some detail. And as well I'm going to talk a little bit about the post-intubation drugs as well. So I'm going to get started with the induction agents. And there's a wide variety of induction agents that are routinely used in children. And it's important that you know a little bit about their pharmacology, so that you know their mechanism of action, their individual advantages and disadvantages, common side effects and contraindications, so that you can pick the best induction agent for your child in whatever situation you find yourself in. So I'm going to start off with 3 of the most common induction agents, ketamine, propofol and thiopentone, and look at their individual properties in a bit more detail. So looking at ketamine first of all, so ketamine is a phenylcyclidine derivative that is an antagonist of the NMDA receptors, and it causes dissociative anesthesia, having hypnotic, analgesic and also local anaesthetic properties. It comes in a clear colour solution in 10 milligrams per mil, 50 milligrams per mil and 100 milligram per mil ampules, and is stable at room temperature. The normal intubating dose is 1 to 2 milligrams per kilogram in a hemodynamically stable patient. And as I'm going to mention with all the induction agents, the dose should be titrated to the patient's hemodynamic state, and hemodynamically unstable patients will require significantly less than the 1 to 2 milligrams per kilogram dose that I've mentioned. Ketamine tends to have its onset in about 30 to 60 seconds. Although the endpoint can be difficult to judge, because with the dissociative anesthesia, the patient's eyes often remain open, so it's not like the other agents that I'm going to go on and talk about. It lasts probably around about sort of 10 to 20 minutes. Recovery afterwards can be slow, so it's a gradual offset. And I suppose one of the main concerns with recovery is emergence phenomenon, where you can get delirium, vivid dreams and hallucinations. And the risk of this emergence phenomenon can be reduced by co-administration with a benzodiazepine. So this emergence phenomenon is probably one of the reasons ketamine is less popular in adult anaesthesia than it is in children. It's probably just as frequent an occurrence in children, but obviously the children can't tell us about it, so it's less recognised. Going on to look at propofol. Propofol is an alkyl phenol derivative which causes hypnotic effects by facilitating inhibitory neurotransmission mediated by GABA. It's available in a 0.5, 1% or 2% lipid emulsion, and the most common one used is a 1% 10 milligram per ml solution for induction of anaesthesia. The normal intubating dose in a hemodynamically stable child is 2.5 to 4 milligrams per kilogram, but as we've mentioned, the induction dose should be reduced significantly in a hemodynamically unstable child. It has an onset in about 30 seconds, lasts about 10 minutes, and unlike ketamine, it has quite a quick, rapid recovery after administration of either a bolus or an infusion. So thiopentone is a thiobarbiturate which causes hypnosis through a number of mechanisms. It inhibits acetylcholine, which is an excitatory neurotransmitter. It facilitates GABA, an inhibitory neurotransmitter, and inhibits the reticular activating system. It comes as a powder to be reconstituted in 500 milligram vials, which are stable at room temperature. To reconstitute it, you add 20 ml of water to the vial to make a 2.5% solution, or 25 milligrams per ml. And once reconstituted, it's stable at room temperature for 48 hours. The normal intubating dose in a neonate is 2 milligrams per kilogram, and for infants and older children, 4 milligrams per kilogram. And as we've mentioned with the other two drugs, the dose should be reduced in hemodynamically unstable children. Thiopentone has a very reliable onset time and well-defined endpoints, acting in about 30 seconds. The duration of action is anywhere from 5 to 15 minutes, and again there's quite rapid recovery after a bolus dose due to redistribution. However, after repeat bolus doses or an infusion, recovery is delayed, unlike propofol. So looking at their effects on other systems. So looking at the airway effects, both ketamine and thiopentone will preserve the airway reflexes, probably more so in ketamine, making it useful from a procedural sedation point of view where you're not going to put an airway in. Ketamine will also cause increased salivation, so this in itself can cause obstruction in the airway, particularly in smaller patients. On the other hand, propofol causes good suppression of the airway reflexes, which facilitates insertion of a laryngeal mask. So going on to look at the respiratory effects of the different drugs. So ketamine tends to preserve respiration. There's really only a couple of children I can think of where I've given them ketamine and they've had an apnea and they've been pretty clapped out. So this makes the drug particularly useful for procedural sedation where you're not going to put a laryngeal mask or endotracheal tubing, because the children most of the time will continue breathing adequately after a good dose of ketamine. On the other hand, both propofol and thiopentone, apnea is fairly common after the administration for a short period of time before respiration will come back again. Looking at their effects on the lower airways, ketamine has the advantageous property of causing bronchodilation, and for this reason it's the ideal drug to be used in status asthmaticus, and we'd often use ketamine in it as continuous infusion in the paediatric intensive care unit when dealing with children with asthma for that very property. Thiopentone tends to have the opposite effect in asthmatics and can cause bronchospasm due to the release of histamine, so it's better avoided in asthmatics. Going on to look at the cardiovascular effects, this is one of ketamine's key advantages. It's a relatively cardiostable induction agent, and it works to increase the heart rate, increases the blood pressure, and increases the cardiac output in a stable child. And it does this by increasing the sympathetic tone by blocking noradrenaline uptake by the sympathetic nerve endings. On the other hand, both propofol and thiopentone tend to cause a reduction in blood pressure and a reduction in cardiac output. Thiopentone will normally cause slight elevation in the heart rate, whereas propofol can cause both bradycardia and tachycardia. With propofol, the cardiovascular effects occur as a result of vasodilatation, and with thiopentone are partially caused by vasodilatation, but thiopentone also reduces the contractility of the heart. And it's the negative effects on the cardiovascular system caused by propofol and thiopentone which limit their use in the critically ill child. Okay, so going on to look at the neurological effects, ketamine tends to cause increased cerebral blood flow, increased cerebral metabolic rate, increased cerebral oxygen demand, and increased intracranial pressure, and as a result maintains cerebral perfusion pressure because although the intracranial pressure goes up, so does the blood pressure. Propofol and thiopentone tend to have the opposite effects. Both they cause reduced cerebral blood flow, reduced cerebral metabolic rate, reduced cerebral oxygen demand, reduced intracranial pressure. Although they reduce intracranial pressure, because they also tend to cause hypotension, generally reduce cerebral perfusion pressure. However, in the intensive care unit, the drop in blood pressure that's caused by thiopentone can be offset with a noradrenaline infusion, allowing a continuous infusion of thiopentone to be used to help control refractory high intracranial pressure in children following traumatic brain injury. Looking at the other neurological effects of these drugs, ketamine has analgesic effects, where the other two agents, propofol and thiopentone, don't have any analgesic effects. So this is particularly important if the patient's having a painful procedure done. You need to be aware that propofol and thiopentone won't provide any pain relief, whereas ketamine does have some analgesic properties. The other useful property ketamine has over the other two is it has local anaesthetic effects as well, meaning it can be added into epidurals. All three of the agents have anti-epileptic effects. Propofol and thiopentone are quite useful for the induction agent when you're intubating a patient with status epilepticus, and thiopentone is the preferred agent as per the APLS guidelines. Ketamine is useful for refractory status epilepticus in the intensive care unit when other agents have failed, although generally isn't used for the intubation of children with status epilepticus. Going on to look at the gastrointestinal effects, ketamine is associated with postoperative nausea and vomiting, whereas propofol is generally an antiemetic. What is important to note with thiopentone is that it does reduce splenic blood flow and also blood flow to the kidneys. This is more of a problem when thiopentone has been used as a continuous infusion in the intensive care unit, being aware that your child is slightly increased risk of NEC because there's less blood flow to the gut, and also renal disease because of less blood flow to the kidneys. Going on to look at the contraindications, so obvious contraindication to ketamine is an allergy to it, because it can cause increased blood pressure. If your patient is extremely hypertensive, it's probably contraindicated as well, and also in ischemic heart disease due to its cardiovascular effects. Looking at propofol, obviously again if you're allergic to propofol you should avoid it, and due to its constitution, if you're allergic to eggs, soybean or soy, again it should be avoided. Probably the biggest contraindication to both propofol and thiopentone is cardiovascular instability. So if your child is highly likely to decompensate on induction, propofol and thiopentone will probably push them over the edge, so it should be avoided in a cardiovascularly or potentially cardiovascularly unstable patient. Other contraindications to thiopentone, obviously if you're allergic to barbiturates, if you've got porphyria, acute severe asthma, or myotonic dystrophy. Going on to other information about the drugs, looking at ketamine, it's important to note that ketamine can cause increased intraocular pressure, so it should be avoided if you know your patient has this or they have a penetrating eye injury. And another useful route that ketamine can be given is intramuscularly in an emergency. It's generally given in a slightly higher dose of about 4 milligrams per kilogram, but still acts reasonably quickly. Propofol and thiopentone can both cause pain on injection. Thiopentone has quite an alkaline pH, so extravasation of it tends to cause tissue necrosis, and arterial injection is highly likely to cause thrombosis and limb ischemia. So the point for this is don't give thiopentone into a cannula that you're not sure is in a vein or that could potentially be in an artery. So for me, it's generally a cannula I put in myself, or I've seen somebody put it in and I'm happy it's a good cannula. The other thing probably to say with thiopentone is don't mix it with Suxamethonium, because the increased pH will deactivate the Suxamethonium. Final thing to say about propofol is it's routinely used in adults in intensive care units for sedation due to its beneficial properties of quick recovery when it's turned off. Unfortunately, we can't use it for this property in children in paediatric intensive care due to the risk of propofol infusion syndrome. Okay, so going on to look at some of the other induction agents. So like ketamine, etomidate is a relatively cardiac stable induction agent. However, its use is associated with increased mortality in critically ill patients. It causes suppression of the adrenocortical axis, and therefore we can't recommend it as an induction agent. Fentanyl, which is a synthetic opioid, although not truly an induction agent, when given in a high dose of roughly 3 to 5 mics per kilo, whereas a normal analgesic dose is 1 mic per kilo, provides quite a smooth induction agent, which is relatively cardiac stable. And the main places fentanyl tends to be used as an induction agent is in neonatal units and during cardiac anaesthesia. As I said, fentanyl is relatively well tolerated from a cardiovascular point of view, and its main side effect is chest wall rigidity, which is particularly problematic in neonates. This side effect can be avoided by giving the drug slowly, and it's recommended that it's given over roughly about 2 minutes. Particularly important when you're doing this in small babies, you need to factor in your dead space when doing this. So importantly, when you start to give the fentanyl, all you'll be doing is filling the dead space off the connector and the cannula. And then when you start to flush the drug, you're still actually giving the fentanyl that's in the dead space. And quite often in particularly small neonates, the dose of fentanyl that you've drawn up is less than the dead space. So the whole time you're giving the fentanyl, all it will be doing is going into the dead space. People flush it in really slowly over 2 minutes, but the patient hasn't got it yet. And then when they give the flush, they flush it quickly, and all of a sudden the patient gets the dose at once and you get chest wall rigidity. So you need to factor in your dead space when you're giving the drug. Should chest wall rigidity occur, the best treatment is to give a fast-acting muscle relaxant, which you should be doing anyway. The other place fentanyl is used is often administered along with another induction agent due to its useful property of blocking the sympathetic response to laryngoscopy, and normally in a dose of 1 mic per kilo for this purpose. Morphine I've mentioned because I know that some neonatal units use this as their induction agent, and this practice we really can't support due to the unfavourable pharmacokinetic properties of morphine. So morphine has a really slow onset. It's going to take at least 10 minutes to have any hypnotic effect, and it has a long duration of action. We're normally giving morphine 4 to 6 times a day, So you can expect the morphine to last 4 to 6 hours when it's given. So this is really the opposite of what an induction agent should do. An induction agent should act quickly and go away quickly, whereas with morphine it acts slowly and lasts for a long time. It also produces poor levels of hypnosis, produces more hypotension than with fentanyl due to its histamine release. And when you consider there's actually better induction agents with less side effects that will work in a better way, we really can't support morphine for use as this purpose. Midazolam, again, not necessarily a true induction agent, but is often co-administered with another induction agent or used for pre-medication because it causes amnesia and anxiolytic properties. You can use it as a higher dose as the sole induction agent, but it has a slightly slower onset and longer duration of action than the 3 preferred induction agents for use in children, and it's highly likely to cause cardiovascular instability as well in a critically ill child. So that was a quick run through the common induction agents, their advantages and disadvantages, and this is particularly more important when you've got an elective intubation in a well child, because you've got more of a choice and you can pick and choose from the agents that I've mentioned, depending on their individual properties. But when it comes to intubating the critically ill child, you really don't have much of a choice. Your choice of induction agent is determined by its cardiovascular stability, because the critically ill child is highly likely to decompensate on induction of anaesthesia. So you need to pick the agent that's going to make that process as smooth as possible by having the minimal effects on the cardiovascular system. And for this reason, ketamine is the preferred induction agent for the intubation of the critically ill child. It is important to note that I've told you that in a well child, ketamine normally causes hypertension and tachycardia due to its effects on the sympathetic nervous system. The critically ill shocked child isn't going to have the same effects. They've already exhausted all their own endogenous catecholamines, so they are likely to react with hypotension on administration of ketamine. However, that effect is hopefully going to be less than with use of some of the other induction agents such as propofol and thiopentone. So how does this affect what you do? Well, I told you the normal induction dose of ketamine was 1 to 2 milligrams per kilogram in a hemodynamically stable child. So when you've got a shocked child, you need to reduce this dose. So for a hemodynamically stable child, I'm starting normally about 1 milligram per kilogram, because you can always give more, but you can't take it away. And in the shocked child, I'll drop this down to 0.5 milligrams per kilogram. Importantly, you need to allow more time for the drug to work, because it's going to take longer to get from the cannula to the patient's brain because of the impaired circulation time. So if you don't wait long enough and give another dose, it's all going to hit at once, and it's likely to have undesirable cardiovascular effects. Another tip I'll give you is that I've already mentioned ketamine comes in 3 preparations: 10 milligrams per mil, 50 milligrams per mil, and 100 milligrams per mil. So for intravenous administration, I would recommend that you always use the 10 milligrams per mil solution, and that's for 2 reasons. It's much easier to calculate the dose you need to give if your drug comes in a multiple of 10, for example 10 milligrams per mil. So you're going to have less risk of drug errors. And it's important you always use the preparation the same way. So if sometimes you're using 10 milligrams per mil, other times 50 milligrams per mil, you're more at risk of making an error. So if you only have the 50 milligrams per mil on a certain occasion, I would recommend you dilute it down to 10 milligrams per mil, so that you're always administering 10 milligrams per mil strength. The second reason for using this concentration is that in small neonates, you're going to need this dilute to drop the small volume you need accurately. Another important point I want to clarify is the use of ketamine in patients with traumatic brain injury, and so at increased risk of intracranial pressure. So traditionally, this was a contraindication to using ketamine because there was concerns that ketamine can cause increased intracranial pressure, so could cause harm. And for years, drugs like thiopentone were given because they reduced intracranial pressure, so were meant to infer a benefit. The problem with this is that although thiopentone reduces intracranial pressure, it also has a significant effect on the cardiovascular patient, particularly a sick trauma patient. Given a dose of thiopentone is likely to drop their blood pressure. And in so, by dropping their blood pressure, the cerebral perfusion pressure to the brain will drop, even though intracranial pressure is reduced. On the other hand, by giving ketamine, although it may cause a slight elevation in intracranial pressure, and the studies showing this were conducted some time ago, and the evidence is actually fairly weak that it does elevate intracranial pressure, and there has never been any association of harm caused by this slight elevation in intracranial pressure. But the big advantage of ketamine is that it is generally cardiovascular stable, so shouldn't produce that same reduction in blood pressure. And so, although intracranial pressure will elevate slightly, cerebral perfusion pressure is generally maintained and doesn't drop like it does with the administration of propofol or thiopentone. So for me, I'm using ketamine routinely in my traumatic brain injury patients, and I would never think of using propofol or thiopentone because I'm much more interested in preserving the cerebral perfusion pressure rather than worrying about small changes in intracranial pressure. Obviously, when it comes to ongoing boluses after intubation or sedation in the intensive care unit, then I would probably stay away from ketamine and use other agents for this purpose. But for that initial intubation, where the patient's likely to decompensate because they're a trauma patient, they may be shocked, the advantages of ketamine outweigh any disadvantages for me. So I'm using ketamine pretty much for all my intubations in critically ill children. I suppose the one exception is the child in status epilepticus, where I would generally use thiopentone as the first line agent. You could use propofol, it will do equally a job as thiopentone, but as current APLS guidelines recommend, thiopentone is probably best to stick to this for the purpose of status epilepticus. I suppose the one situation where I probably wouldn't use thiopentone is the patient in status epilepticus who is also hemodynamically unstable. In this situation, I'd use ketamine for induction of anaesthesia and then worry about treating the seizure after the airway's been secured. Okay, so now I want to go on and talk about the muscle relaxants. So the muscle relaxants can be divided up into two types, depolarizing and non-depolarizing, based on their mechanism of action. And to explain how they work, you need to have a basic knowledge of how transmission occurs at the neuromuscular junction. So when an action potential arrives at the nerve ending, it causes release of acetylcholine into the synaptic cleft, which is the gap between the nerve and the muscle fibre. And as this acetylcholine molecule then transverses across the synaptic cleft and binds to the postsynaptic membrane, which then causes depolarization and muscle contraction. The acetylcholine molecule is then broken down by the enzyme acetylcholine esterase, which is present in the synaptic cleft. So Suxamethonium is really the only depolarizing muscle relaxant used routinely today, and it, as a chemical structure, really consists of two molecules of acetylcholine joined together, and it works by mimicking the action of acetylcholine in the synaptic cleft, where it binds to the postsynaptic acetylcholine receptors and causes depolarization of the muscle fibre. Unlike acetylcholine, it's not broken down by the enzyme acetylcholine esterase, which is present in the synaptic cleft, and it's actually metabolized by plasma cholinesterase present in the blood. As a result of this, the breakdown process is slower, and so depolarization is prolonged, leading to a period of muscle relaxation, after the initial contraction caused by the binding of the suxamethonium to the postsynaptic membrane receptors. And this explains why initially you get some fasciculations when suxamethonium is given, immediately followed by a period of muscle relaxation. As their name suggests, the non-depolarizing muscle relaxants, they don't cause depolarization of the muscle, and they work by competing competitively with acetylcholine for the postsynaptic acetylcholine receptors, and by binding to them, they prevent acetylcholine from binding the receptors and therefore causing depolarization and contraction of the muscle fibre, and that's how they cause muscle relaxation. The non-depolarizing muscle relaxants can be further divided into two groups. There's the aminosteroidals, such as rocuronium, vecuronium, and pancuronium, and there's the benzoquinolinams, which are atracurium, cisatracurium, and mevacurium. And it's useful to have this divide when you're looking at the properties and side effects. So now what I want to do is I want to go on and look at suxamethonium and three of the most common non-depolarizing muscle relaxants, rocuronium, vecuronium, and atracurium, and compare them. So starting off with suxamethonium, as we've already mentioned, suxamethonium is a depolarizing muscle relaxant, and its primary use is in rapid sequence induction. It comes as a clear coloured solution in 50 milligrams per ml in 2 millampules, and should be stored in the refrigerator at 4 degrees C. Once it's removed from the fridge, it's stable at room temperature for 14 days. It's given in a normal intubating dose of 2 milligrams per kilogram for those less than 1 year, and 1 milligram per kilogram above 1 year. It's the fastest acting of all the muscle relaxants, providing intubation conditions after about 30 to 45 seconds, and has the shortest duration of action of 3 to 5 minutes. Rocuronium is a non-depolarizing aminosteroidal muscle relaxant, and it can be used for rapid sequence induction, elective intubation, and also for maintenance of paralysis. It comes in a solution of 10 milligrams per ml in both 5 ml or 10 ml vials. Like suxamethonium, it should be stored in the refrigerator, but can last for slightly longer out of the fridge. It's stable at room temperature for 3 months. For elective intubations, it's given in a dose of 0.6 milligrams per kilogram, where you can expect it to work and provide intubating conditions somewhere between 1 to 2 minutes of time. In rapid sequence, it can be given in a bigger dose, 1 to 1.2 milligrams per kilogram, where you can expect intubating conditions after 45 to 60 seconds. It is a much longer duration of action, 30 to 40 minutes. Vecuronium is another aminosteroidal non-depolarizing muscle relaxant, used for elective intubation and maintenance of paralysis. I haven't mentioned rapid sequence induction because it has a much slower onset of action, taking 2 to 3 minutes to act. It provides a duration of about 30 minutes when given in a dose of 0.1 milligrams per kilogram. The main difference between it and the other ones we're going to mention that it comes as a powder in 10 milligram vials that needs to be reconstituted before being used, but does have the advantage that it's stable at room temperature. Atracurium is a benzoquinoliname non-depolarizing muscle relaxant, which is used again for elective intubation and maintenance of paralysis. Again, not suitable for rapid sequence induction because it takes 2 to 3 minutes to have an effect, and lasts slightly shorter than the other two at about 20 to 30 minutes. It's given in a dose of 0.5 milligrams per kilogram. It comes in 10 milligram per ml vials in 2.5, 5 and 25 mils. Again, it should be stored in the fridge, but once removed from the fridge is stable at room temperature for 14 days. So going on to look at the side effects of these 4 agents, Suxamethonium by far has the most side effects. Probably the most relevant one is bradycardia. So this occurs most frequently in neonates or following administration of a second dose of Suxamethonium. So it's important that you have some atropine to hand if you're using Suxamethonium. Because it works by causing initial stimulation of the muscle followed by relaxation, the fasciculations can cause some myalgia following its use. The other main side effect is hyperkalemia, and in a generally healthy ambulant person, the potassium will go up by about 0.5 millimoles per litre following a dose of Suxamethonium. However, if the patient is already hyperkalemic or has renal failure, this increase in potassium can obviously be significant. Or if the patient is particularly immobile or has an underlying muscle problem due to upregulation of the receptors, you can get much more release of potassium, and fatal hyperkalemia has occurred following a single dose of Suxamethonium. Suxamethonium does increase intraocular pressure, so it should be used with caution in penetrating eye injuries. It increases intracranial pressure and also intragastric pressure, although it does increase the upper esophageal sphincter tone, offsetting some of this rise in intragastric pressure. Like all the drugs, there's risk of anaphylaxis. There's Suxamethonium apnea, where instead of lasting the 3 to 5 minutes, the Suxamethonium can last for a period of hours in patients at risk of this condition. And also there's a risk of malignant hyperthermia. The rest of the agents have much lower side effects. They all have anaphylaxis down as a risk and allergy. Rocuronium tends to cause slight elevation of the heart rate due to its mild vagolytic effects, but this can be slightly advantageous. As I said, bradycardia is fairly common during intubation. Vecuronium is relatively stable and has minimal cardiovascular effects. I suppose the main additional side effect to anaphylaxis with atracurium is histamine release, and this can cause bronchospasm, hypotension, flushing and rash, so it should generally be avoided in asthmatics. So when you know the side effects, the contraindications then make sense. So with Suxamethonium, it's obviously, if you're allergic to Suxamethonium, you shouldn't give it. If there's a family history of or personal history of Sux apnea, it shouldn't be given. Likewise with a history of malignant hyperthermia. If your patient's got a high potassium level, because it will elevate the potassium, it shouldn't be given. Or if your patient has burns greater than 10% body surface area or spinal cord injury after the first 24 hours, again, Suxamethonium shouldn't be given. Again, with significant muscle trauma or prolonged immobilization or a history of muscle disease, you can get significantly high levels of potassium released following a single dose. So Suxamethonium should be avoided. With the other 3 non-depolarizing muscle relaxants, there's relatively few contraindications. Certainly an allergy to the specific drug, it should be avoided. And with atracurium, because it causes histamine release, it should be avoided in asthmatics because it can make bronchospasm worse. Looking at reversibility with Sugammadex, Suxamethonium and atracurium can't be reversed, but the immunosteroidals can, rocuronium and vecuronium. Just a few more comments about the individual drugs. So as already mentioned, Suxamethonium is the fastest acting agent. It can also be given intramuscularly in an emergency when intravenous access isn't available. It's given in a slightly higher dose of 4 milligrams per kilogram, up to a maximum dose of 150 milligrams, and you can get intubating conditions between 2 to 3 minutes later. As we've already mentioned, it's important not to mix Suxamethonium with thiopentone, because the alkaline pH of thiopentone will inactivate the Suxamethonium. Under rocuronium, it's important to note that by giving the RSI, the bigger dose of rocuronium, you can get intubating conditions which are similar to those achieved with suxamethonium in almost the same time, but without a significant number of the side effects that suxamethonium causes, and also there's much less contraindications to its use. A useful feature of atracurium is that it is metabolized by Hoffmann elimination, which means you don't need to reduce the dose in liver or renal impairment. And this is much more important when the muscle relaxant is given by continuous infusion in the intensive care unit rather than after a single bolus dose. I want to go on and talk about a few of the other muscle relaxants. So cisatracurium is actually one of the isomers of atracurium, atracurium being made up of 10 isomers. And the isomer that's used for cisatracurium is actually one of the more potent isomers found in atracurium. And as a result, it needs to be given in a lower dose. It's typically given in a dose of 0.15 milligrams per kilogram. Cisatracurium also shares the advantageous property of Hoffmann elimination with atracurium. However, it doesn't share one of atracurium's big side effects, which is histamine release. So cisatracurium doesn't cause histamine release. Cisatracurium has a slower onset of action, taking about 3 to 4 minutes to work, and lasts slightly longer than atracurium, in about 30 to 40 minutes at a time. It's also more expensive than atracurium. Mivacurium is given in a dose of 0.15 to 0.2 milligrams per kilogram. It's a similar onset of action to atracurium, but has a shorter duration of action, lasting about 15 minutes. When it's used, histamine release is relatively common though. Pancuronium is a steroidal non-depolarizing muscle relaxant, which is normally given in a dose of 0.1 milligrams per kilogram. It also has a slow onset of action in about 3 to 5 minutes, and has a much longer duration of action than any of the other muscle relaxants we've mentioned, and you can expect paralysis for 40 to 60 minutes following a single bolus. Following administration, it does tend to cause tachycardia and hypertension due to its sympathomimetic properties. So now I want to go on and talk a little bit about muscle relaxant reversal. So all the non-depolarizing muscle relaxants that we've mentioned can be reversed using anticholine esterases such as neostigmine, and these are often given in combination with either atropine or glycopyromium to minimise the muscarinic side effects. So the anticholine esterases work by inhibiting the enzyme acetylcholine esterase in the neuromuscular junction. So by inhibiting this enzyme from breaking down acetylcholine, they increase the amount of acetylcholine present in the synaptic cleft, meaning there's more acetylcholine molecules available to compete with the muscle relaxant for position on the postsynaptic acetylcholine receptors. So while anticholine esterases are used routinely to reverse the effect of muscle relaxants at the end of a case in the operating theatre, they're not so helpful in the setting of field intubation, because they generally aren't given until at least 15 to 20 minutes after administration of the muscle relaxant. So they're not useful in that setting where you've given the muscle relaxant, can't intubate the child, and you want to reverse things immediately. I have, however, mentioned them because I think I need to cover them for completeness, because when we talk about reversing muscle relaxants in that setting of field intubation, this is what most people think we're talking about, and it's not. There's actually another class of drug more recently discovered called Sugammadex. That is the drug we're talking about for the immediate reversal of certain types of non-depolarizing muscle relaxants immediately after they've been given. So Sugammadex works in a slightly different way. It's a selective relaxant binding agent, and it works by encapsulating certain groups of muscle relaxants, so only the aminosteroidal group of non-depolarizing muscle relaxants. So once the aminosteroidal group muscle relaxant molecules have been encapsulated by the Suxamethonium, they can't exert their effect, and they are then excreted by the kidneys. So if you give a dose of 16 milligrams per kilogram of Suxamethonium immediately following the administration of aminosteroidal neuromuscular blocking agent, so that's importantly either rocuronium, vecuronium or pancuronium, you can expect recovery within 1 to 3 minutes. And it's important to mention that Suxamethonium will have absolutely no effect on the benzoquinoliniums, so that's antracurium, cisatracurium or mivacurium. Okay, so that's a quick run through the different muscle relaxants, divided up into depolarizing and non-depolarizing, and then the non-depolarizing into the aminosteroidals and the benzoquinoliniums. So when it comes to intubating the critically ill child, like with the induction agents, you don't have a big a choice as you think, and the drug that you choose as your muscle relaxant, the biggest determining factor here is the onset of action. So although it's rare we would perform a classical rapid sequence induction in the critically ill child, you still want your muscle relaxant to work as quickly as possible. And that's because while you're waiting for the muscle relaxant to work, we'd normally provide face mask ventilation to the child during the apnea period while you're waiting for the muscle relaxant to take effect prior to intubation. And that face mask ventilation isn't without complication. There's obviously risk of failed or inadequate mask ventilation leading to hypoxia. It can also cause gastric distension, impairing ventilation and increasing the risk of aspiration. And also while you're spending time bagging the patient, you're not doing all the other jobs you need to be doing with the child. So it makes sense that you choose a faster acting muscle relaxant so you limit that period of mask ventilation. And for that reason, there's really only 2 drugs that are appropriate for use in the intubation of the critically ill child, and that's Suxamethonium and an RSI dose of rocuronium, because they're the only 2 agents that provide good intubating conditions in less than 1 minute. And all the other muscle relaxants that I've told you about take at least 2 minutes to provide similar intubating conditions. So if you don't want to bag your child for an extra minute, at least, you're limited to a choice of either Suxamethonium and rocuronium. The next thing to consider is that when you look at the side effect and contraindications to Suxamethonium and compare them to rocuronium, and when you consider that rocuronium is only 15 seconds slower in producing good intubating conditions than Suxamethonium, for this reason I would recommend using rocuronium as the muscle relaxant of choice when intubating a critically ill child. I would also recommend using a dose of 1 milligram per kilogram for ease of calculation, and also because a dose of 1.2 milligrams per kilogram doesn't provide faster intubating conditions than a dose of 1 milligram per kilogram. But the 1 milligram per kilogram dose is going to be much easier to calculate. It's going to be 0.1 mils per kilo of the 10 milligram per mil solution. Also, because we've already mentioned with ketamine, we're normally starting in a dose of 1 milligram per kilogram, and ketamine's also 10 milligrams per mil is the strength I've recommended using. The volume that you're drawing up for both your ketamine and your rocuronium is normally the same. So again, another good reason to use 1 milligram per kilogram of rocuronium. Is there any situations where I would recommend using Suxamethonium over rocuronium? And probably the couple of situations where I would recommend it are, for example, in neonates, they would intubate the babies for respiratory distress syndrome, where they often use an INSURE technique, so intubation, surfactant and extubation. So they want to extubate the baby immediately after the procedure. So in this situation, Suxamethonium is a better choice because its duration of action is going to be 3 to 5 minutes rather than 30 to 40 minutes with rocuronium. But obviously recognising that there's a high risk of bradycardia when using Suxamethonium in neonates, and making sure you've had some atropine prepared. The other situation where you might want to use Suxamethonium in preference to rocuronium is where the patient may have a potentially difficult airway, or where an intubation has to be carried out without senior support on site. In this situation, the shorter duration of action of Suxamethonium may outweigh any of its side effects. Okay, so the final class of medications that I want to talk about is the rescue medications. So these are the drugs that you give to deal with the common complications caused by the process of intubation or the administration of the induction agents, and these are primarily bradycardia and hypotension. So I'm going to deal with bradycardia first. So the actual process of laryngoscopy can cause bradycardia by itself. If the intubation is prolonged and there's hypoxia, that can cause bradycardia through vagally mediated methods. Also, we've mentioned some of the drugs that you give, both the induction agents and the muscle relaxants can cause bradycardia. So this means bradycardia is a predictable side effect of intubation, and you must be prepared to deal with it. So I would recommend you draw up atropine in advance for every intubation. Although it can be drawn up quickly in an emergency in about 30 to 60 seconds, that's a very long time to be watching a bradycardic child, and it's much better to have it drawn up in advance. So the dose of atropine to treat vagally mediated bradycardia is 20 micrograms per kilogram, up to a maximum dose of 600 micrograms. Sometimes in high-risk patients where you think there's a high risk they're going to develop a bradycardia, prevention is felt to be better than cure, and you may want to give the atropine prophylactically on induction, so to try and prevent bradycardia before it recurs. In this situation, the dose is the same. It's 20 mics per kilo, up to a maximum dose of 600 micrograms, with one exception. And that is that in patients older than 1 month, a minimum dose of 100 micrograms is used for atropine. And that's because there's concerns that the smaller doses are associated with paradoxical bradycardia. So atropine comes in a variety of forms. It comes in 1 ml ampules containing 600 mics, so 600 mics per ml. Or it can come in a pre-filled syringe of various concentrations and sizes, from 100 mics per ml, 200 mics per ml, or 300 mics per ml. And as we've mentioned before, for ease of calculation, you want to do this the same way every time. And as we've mentioned, multiples of 10 or 100 are much easier for working out the dose, rather than funny concentrations like 200 mics per ml or 300 mics per ml or 600 mics per ml. So with this in mind, I would recommend you always give atropine in a dose of 100 mics per ml. If you've got a pre-filled syringe of this concentration, great, use it. If not, what I'd recommend you do is you take the 1 ml ampule containing 600 micrograms and dilute it with 5 mils of 0.9% saline. So you've got a solution now, 6 mils containing 600 micrograms, which is 100 micrograms per mil. So as we've already mentioned, all the induction agents have the potential to cause cardiovascular collapse in the critically ill child. And even with your best efforts of trying to optimise the child prior to the induction of anaesthesia, and by limiting the dose of the induction agent and choosing a cardiostable agent, you can't always prevent hypotension from occurring. So you need to have a plan to treat it when it occurs. And it's normally managed in a combination of fluid boluses and push dose pressors. And I'll talk about the fluid boluses first. So fluid boluses in children are normally given in aliquots of 10 to 20 mils per kilo, and they're normally drawn up in a large volume syringe and pushed in by hand. And this significantly reduces the time to administration. It does, however, take some time to fill the syringes from the bag, so if you think your child is at high risk of developing hypotension on induction, it makes sense to have the syringes already filled with the fluid of your choice, which is normally normal saline, prior to inducing anaesthesia. And for the situations where you haven't anticipated hypotension and it occurs, it's important that you have a bag of appropriate fluids available and a bag spike, because this means you can rapidly fill the syringes and give the bolus. So as we've already mentioned, all the induction agents can cause hypotension, and it's normally through a combination of vasodilatation and a direct depressant effect on the contractility of the heart. And while fluids will be helpful to deal with some of this, in other situations you actually need push-dose pressors to bring the blood pressure back up. So what do I mean by push-dose pressors? Well, normally vasoactive drugs are given in concentrated infusions via a central line. In contrast, push-dose pressors are titrated by administering small aliquots from a dilute vasoactive drug syringe by bolus injection, and this can be via a peripheral line. And due to the speed that this can be initiated, push-dose pressors are generally used in two main situations: the crashing peri-arrest patient, where you don't have time to start a vasoactive drug infusion. It would be too long and the patient would deteriorate too quickly. Or the other situation, which is the situation we're talking about, is where you expect the hypotension to be short-lived, making a standard infusion unnecessary. And this is generally the hypotension caused by the induction agent on induction of anaesthesia. So there's a whole range of drugs that you can use as push-dose pressors. We're focusing solely on the emergency intubation of the critically ill child here, and for this situation adrenaline is by far the best and most effective agent, and most importantly it's in the resuscitation trolley on every ward, so you have easy access to it. So how do you make up push-dose adrenaline? Well, it's really simple. It's 1/10 the strength of the dose of adrenaline you use in a cardiac arrest. So it's adrenaline 1 in 100,000, whereas in a cardiac arrest you use 1 in 10,000. So there's 10 micrograms per mil in adrenaline 1 in 100,000. So to make it up, all you do is you take 1 mil off the adrenaline 1 in 10,000 that you would be using in a cardiac arrest, add 9 mils of saline to it, so you've now got 10 mils containing adrenaline 1 in 100,000, or 10 mics per mil. So you give exactly the same volume that you would in a cardiac arrest, 0.1 mils per kilo, up to a maximum dose of 2 mils. And because you've already diluted it by 10, by giving the same volume as you would in a cardiac arrest, 0.1 mils per kilo, you're actually given 1/10 of the dose. So you're only given 1 microgram per kilogram at a time. In an adult, the normal dose you would give is up to 2 mils of this solution, or 20 micrograms, so that's why you don't exceed 2 mils. And how often can you give this? As often as you need to. So it's generally between every 30 seconds or 10 minutes. And certainly if you're needing to give this for a prolonged period of time, you should be thinking of converting it over to an infusion. Okay, I want to finish by talking a little bit about the post-intubation drugs. So following intubation, it should be remembered that the effects of the muscle relaxants will persist for longer than the induction agents. That is, unless you've used Suxamethonium. So maintenance of sedation should be started as soon as possible, to prevent the situation where the child is actually conscious but paralysed. On the situation where you expect the duration of intubation to be short, for example, you've only intubated the child for a procedure, or for example, if following a status epilepticus and you're planning to wake and extubate. To cover that period while you're waiting for the muscle relaxant to wear off and allow the child to wake, it's probably best done by giving further boluses of the induction agent as required. However, most of the times when we're intubating a critically ill child, they're going to need a trip to intensive care, so sedation is going to be needed for a longer period. And in this situation, you're much better to start a continuous infusion of sedation. So I'm going to tell you my approach to sedation following intubation. It's important to note that this varies widely. The doses and the drugs used vary widely, so this is just one approach. But you should use whatever approach is used locally. So most children following intubation, I'm starting on morphine as my maintenance of sedation. And in general, I'm making up the child's weight in kilograms of morphine in 50 mils of 0.9% saline. So if I've got a 18 kilo child, I'm making up 18 milligrams of morphine in 50 mils. For a 40 kilo child, it's 40 milligrams of morphine in 50 mils. And if I start that infusion at 1 mil an hour, I'm going to be given 20 micrograms per kilogram per hour. And I would normally start at 1 mil an hour and titrate to effect. And the normal range for a morphine infusion is somewhere between about 10 and 60 micrograms per kilogram, or 0.5 to 3 mils if you've made the infusion up the way I'm telling you. And in general, we'd use a lower dose in neonates, maybe up to about 20 or 30 micrograms per kilogram per hour at most, with the higher doses of up to 60 being for older children. With any of the infusions, you do need to give a loading dose rather than just starting the child on the maintenance dose. With the morphine, your loading dose varies somewhere between about 20 and 100 micrograms per kilogram, or 1 to 5 mils of the reconstituted infusion if you're making it up, as I've told you. And how much of that you give depends on their child's requirement and also their hemodynamic status. What I tend to do is give the dose in 1 to 2 mil aliquots of 20 to 40 micrograms at a time and titrate that to effect. So in infants less than 3 months, I normally use morphine alone for sedation because the addition of midazolam is not only unnecessary, but it's associated with frequent hypotension, oversedation, and then withdrawal when you're stopping the sedation. However, in infants over about 3 months of age, you generally do require midazolam on top of the morphine to get adequate levels of sedation. So how do we make up a midazolam infusion? It's normally 5 times the child's weight in milligrams of midazolam, made up to 50 mils with 0.9% saline. So for example, you have an 18 kilo child, that's 90 milligrams in 50 mils of 0.9% saline. Again, starting at 1 mil an hour will give you 0.1 milligrams per kilogram per hour, and that's what I would normally start at and titrate it to effect. The range with the midazolam infusion is 0.6 to 2.4 mils an hour, which is 0.06 to 0.24 milligrams per kilogram per hour. And like with the morphine, it is important that you give a loading dose if you don't want the child to wake up between the effects of your induction agent and the continuous infusion taking effect. How much do you give them? It's normally between about 50 and 100 mics per kilo of midazolam, or 0.5 to 1 mils of the reconstituted solution, provided you've made it up the way I've told you to make it. And again, that depends on the patient's hemodynamic stability and also their requirement. And I would suggest giving this in 0.5 mil or 50 microgram aliquots. So apart from local preference, the main reason to deviate away from what I've recommended, morphine alone in children less than 3 months, morphine and midazolam in children over 3 months is in asthma. In this situation, the morphine, due to its histamine release, can worsen bronchospasm. So I tend to avoid morphine in this group of patients. And because ketamine actually has bronchodilatory properties, I would substitute the morphine for a ketamine infusion, and often combine the ketamine infusion with a midazolam infusion. The other important thing to mention with sedation of critically ill children, particularly if you're used to working with adults, is that propofol infusions are contraindicated for sedation in intensive care due to risk of propofol infusion syndrome in children. So generally we're not using propofol. Looking at muscle relaxation, if you need ongoing paralysis, you can do this one of two ways. You can either give a bolus of muscle relaxant as and when they're needed, or you can start a continuous infusion. I suppose one advantage of the bolus administration is that it allows you to assess the neurology and depth of sedation between the doses. And this is particularly important if you've got a child who's at risk of seizures, while the continuous infusion probably provides more stability. If you do want to start a continuous infusion, you can really have your pick of the muscle relaxants that we've discussed. I'm going to describe rocuronium because generally if you're using rocuronium for intubation, it makes sense that you start the same stuff again as a continuous infusion. So I generally make rocuronium infusions up neat. So it's just 500 milligrams and 50 mils neat, or feel free to make up a smaller syringe of 10 milligrams per mil, depending on what you think you're going to use. We generally make up 24 hours worth of an infusion. So the starting dose for this is normally 0.5 milligrams per kilogram per hour. So if you're running rocuronium neat, that's 0.05 times the child's weight in kilograms, mils an hour, and then titrate that to effect. So for example, if you had an 18 kilo child, it's going to be 0.9 mils an hour of a rocuronium infusion, 10 milligrams per mil. The range of that infusion is 0.3 to 1 milligrams per kilogram per hour. If you prefer just to work on bolus doses, 0.6 milligrams per kilogram at a time is about right for that. Okay, to sum up then, I would recommend using ketamine and rocuronium for intubation of most critically ill children. Make sure you reduce the dose of ketamine for hemodynamically unstable patients. Although it is the most cardiac stable agent, it still will cause hypotension in the shocked child. Make sure you've drawn up your rescue medication so it's available should you need it. And remember to start post-intubation drugs promptly following intubation for maintenance of anaesthesia.